Hello, dear friends. How are you doing today? I hope you are doing well. Welcome to a new question about dermatology. A 29-year-old man presents due to the development of hard skin on his scalp. On examination, he has a 9 centimeter circular white hyperkeratotic lesion on the crown of his head. He has no past history of any skin or scalp disorder. Skin scrapings are reported as follows. No fungal elements seen. What is the most likely diagnosis? A. Psoriasis. D. Dissecting cellulitis. C. Carrion. D. Systemic lupus erythematosus. E. Seborrheic dermatitis. Here we have a 29-year-old man coming with a lesion on his scalp. The lesion is 9 centimeters, circular, white, hyperkeratotic. Here the diagnosis can be tinea capitis or psoriasis. Is 9 centimeter. Okay, but the skin scrapings findings show no any result for fungal elements. It means that the patient has no tinea capitis. I think the diagnosis can be psoriasis. Okay, we are going to explain about it. As the skin scraping is negative for fungi, the most likely diagnosis is psoriasis. Scalp psoriasis may occur in isolation in patients with no history of psoriasis elsewhere. The white appearance of the lesion is secondary to the silver scale covering the psoriatic plaque. Psoriasis is a common, the prevalence is around 2 to 3%, and chronic skin disorder. It generally presents with red or salmon pink base, thick, dry silvery white or scaly patches on the skin. Pathophysiology: multifactorial and not yet fully understood. Genetic associated HLA-B13, B17 and CW6. Strong concordance 70% in identical twins. It means that is strongly genetic. Immunological: abnormal T cell activity stimulates keratinocyte proliferation. There is increasing evidence that this may be mediated by a novel group of T helper cells producing interleukin 17 designated T helper 17. These cells seem to be a third T effector cell subset in addition to T helper 1 and T helper 2. Environmental: it's recognized that psoriasis may be worsened, example skin trauma, stress, and triggered, example by streptococcal infection, or improved, example by sunlight or by environmental factors. Recognize subtypes of psoriasis. Plaque psoriasis or psoriasis vulgaris is the most common subtype, approximately 80 to 90% of cases, resulting in the typical well-demarcated red scaly patches affecting the extensor surfaces, sacrum and scalp. An inverse psoriasis or flexural psoriasis appears in skin folds like armpits, groin, under breast, and around genitals. Smooth, shiny red plaques, little to no scaling due to moisture in folds. And guttate psoriasis, transient psoriatic rash, often triggered by streptococcal throat infection. Multiple red teardrop lesions appear on the body, common in children and young adults. Pustular psoriasis, characterized by sterile pustules on red skin. It commonly occurs on the palms and soles. And erythrodermic psoriasis, severe, rare, and potentially life-threatening, widespread erythema and scaling covering most or all of the body surface. Other features of psoriasis: nail psoriasis seen in up to 50% of patients with skin psoriasis, pitting, onycholysis, subungual hyperkeratosis, and oil drop discoloration can be seen. Psoriatic arthritis, inflammatory arthritis in up to 30% of psoriasis patients. joint pain, stiffness, swelling in small joints like fingers or toes, and large joints like knee and spine. Complications: psoriatic arthropathy, increased incidence of metabolic syndrome, increased incidence of cardiovascular disease, increased incidence of venous thromboembolism, and psychological distress. The increased incidence of cardiovascular disease and increased incidence of venous thromboembolism is due to the increased or inflammatory cytokines, and the result is atherosclerosis, which leads to cardiovascular incidence of cardiovascular disease or incidence of venous thromboembolism. Management. Okay, NICE, or National Institute for Health and Care Excellence, recommends a potent corticosteroid applied once daily, plus a vitamin D analog applied once daily, and applied separately, one in the morning and the other in the evening. For example, if the patient is using corticosteroid in the morning, then he or she must use vitamin D analog in the evening for up to 4 weeks as initial treatment. Management of chronic plaque psoriasis. Regular emollients may help to reduce scale loss and reduce pruritus. First line, NICE recommends a potent corticosteroid applied once daily, plus a vitamin D analog applied once daily, applied separately, one in the morning and the other in the evening, for up to 4 weeks as initial treatment. Okay, second line, if no improvement after 8 weeks, then offer a vitamin D analog twice daily. And third line, if no improvement after 8 to 12 weeks, then offer either a potent corticosteroid applied twice daily for up to 4 weeks, or a cold tar preparation applied once or twice daily. And short-acting dithronol can also be used. Okay, using topical steroids in psoriasis. As we know, topical corticosteroid therapy may lead to skin atrophy, stauria, and rebound symptoms. Systemic side effects may be seen when potent corticosteroids are used on large areas, example, more than 10% of the body surface area. NICE recommends that we aim for a 4-week break before starting another course of topical corticosteroids, and this 4-week break is important between starting a new course of topical corticosteroid. They also recommend using potent corticosteroids for no longer than 8 weeks at a time, and very potent corticosteroids for no longer than 4 weeks at a time. If the patient is using potent corticosteroid, the duration must not be more than 8 weeks, and if the patient is using very potent corticosteroid, then the duration must not be more than 4 weeks. Okay, vitamin D analogs. Examples of vitamin D analogs include calcipotriol with their commercial name of Dovonex, and calcitriol and calcitol. Vitamin D analog work by reducing cell division and differentiation. Adverse effects are uncommon. Unlike corticosteroids, they may be used long term. Okay, this is the benefits of vitamin D analogs. They can be used for long term. Unlike coal tar and dithronol, they do not smell or stain. They tend to reduce the scale and thickness of plaques, but not their erythema. This is important. We can see they reduce the scale and thickness of plaques, but the erythema remains. Okay, and this is an important note. They should be avoided in pregnancy because they affect on DNA synthesis. Okay, this is important. They should be avoided in pregnancy. The maximum weekly amount for adults is 100 grams. Okay, steroids in psoriasis. Here we are going to talk about steroids used in psoriasis. Topical steroids are commonly used in flexural psoriasis, and there is also a role for mild steroids in facial psoriasis. If steroids are ineffective for these conditions, vitamin D analogs or tacrolimus ointment should be used second line, but topical steroid is the mainstay of treatment in follicular psoriasis. Patients should have 4-week breaks between courses of topical steroids. Very potent steroids should not be used for longer than 4 weeks at a time. Potent steroids can be used for up to 8 weeks at a time. The scalp, face, and follicles are particularly prone to steroid atrophy, so topical steroids should not be used for more than 1 to 2 weeks per month in scalp, face, and follicular psoriasis. Scalp psoriasis. NICE recommends the use of potent topical corticosteroids once daily for 4 weeks in scalp psoriasis. If no improvement after 4 weeks, then either use a different formulation of the potent corticosteroid, for example, a shampoo or mousse, and a topical agent to remove adherent scale, for example, agents containing salicylic acid, emollients, and oils before application of the potent corticosteroid. Face, follicular, and genital psoriasis. NICE recommends offering a mild or moderate potency corticosteroid applied once or twice daily for a maximum of 2 weeks, and secondary care management. Phototherapy, narrowband ultraviolet B light is now the treatment of choice. If possible, this should be given 3 times a week. Chemotherapy is also used, Soralin plus ultraviolet A light or PUVA. Adverse effect including skin aging and squamous cell cancer. This is notable. Systemic therapy, oral methotrexate is used first line. It is particularly useful if there is associated joint disease, or as we said, psoriatic arthritis. Then methotrexate is used as a first line. Cyclosporine, systemic retinoids, biological agents like infliximab, etanercept, and adalimumab. Ustekinumab, which is an interleukin 12 and interleukin 23 blocker, is showing promise in early trials. Mechanism or action of commonly used drugs. Coal tar probably inhibits DNA synthesis. Calcipotriol, a vitamin D analog that reduces epidermal proliferation and restores a normal horny layer, and we must be careful in using vitamin D analogs in pregnancy. And dithranol inhibits DNA synthesis, wash off after 30 minutes. This is important because it has some side effects like burning and staining. Okay, this was an explanation about psoriasis, its causes, and management and prevention of psoriasis. Thank you for your attention.